Usually when you look at a medical diagnosis, there's this, underlying expectation of precision. Like you break your arm, the x-ray shows a jagged white line, and the clinician just points and says, there's the problem. It's binary, it's visible, and frankly, it's comforting.
Oh, absolutely. It's that clinical desire for clean categorization. We want diseases to just fit neatly into isolated boxes with, straightforward single variable solutions.
But the moment you step into the world of mucosal immunology and human microbiomes, specifically within women's health, that x-ray machine just completely shatters. We are looking at a diagnostic landscape that operates way more like a complex, chaotic rainforest than a simple machine. So welcome to this custom-tailored deep dive.
Glad to be here.
Today, we are immersing ourselves in a highly misunderstood, deeply frustrating condition known as Desquamative inflammatory vaginitis, or DIV. And for you listening, we're unpacking a massive stack of sources today.
Yeah, we've got the latest clinical guidelines from the IUSTI and WHO.
All right, plus extensive research from the Centers for Vulvovaginal Disorders, frontline clinical case studies, and some really advanced microbiological data.
Because the overarching challenge with DIV is that it forces clinicians to look at interacting systems rather than just, isolated symptoms. It is a textbook example of a localized ecosystem collapse.
Okay, let's unpack this, because our mission today is to untangle a very specific, pivotal question you are probably already asking yourself. Can localized DIV cause an elevated vaginal fluid pH that fundamentally disrupts the normal protective microbiome balance?
Right, or is the causality flipped? Does the pH shift cause the DIV?
Exactly. And to understand the collapse of an ecosystem, we obviously have to establish the baseline parameters of the healthy state first.
Yeah, so the baseline of a healthy reproductive age vaginal microbiome is, it's really defined by its acidity. We are looking at a pH environment tightly regulated between 3.8 and 4.5.
Which is pretty acidic, right?
Very, and this isn't a passive state either. It requires constant metabolic heavy lifting by specific strains of beneficial bacteria.
Yeah.
Primarily, we're talking about Lactobacillus crispatus and Lactobacillus ginsenni.
And the sources detailed the specific biochemical loop that maintains this acidity, which I thought was fascinating. It starts systemically with estrogen, right?
Exactly, yeah. Estrogen circulating in the body basically signals the epithelial cells lining the vaginal walls to produce and store glycogen, which is a complex sugar.
Okay.
And as the superficial layers of those epithelial cells just naturally shed over time, they release that glycogen directly into the vaginal lumen.
And that's where the bacteria come in.
Right. The lactobacilli utilize host-produced enzymes, like alpha amylase, to break that massive glycogen molecule down into smaller maltose molecules, which they then ferment.
So they're eating it.
Essentially, yes. And the byproduct of that continuous bacterial fermentation is lactic acid, specifically both D-lactic and L-lactic acid isomers.
It's essentially a localized fermentation process. It's very similar to how you preserve food. Think about pickling. You drop vegetables into an acidic brine, and that extreme pH environment physically prevents the growth of mold or, harmful bacteria by just disrupting their cellular functions.
It's a great way to look at it.
Yeah, it's like the lactobacilli are the bouncers at a club.
Yeah.
By keeping the pH low, like a strict dress code, they're running a continuous pickling process to maintain a chemical shield against troublemakers.
I love that analogy. And we connect this to the bigger picture. This lactic acid literally protonates the cell membranes of invading pathogens.
Oh, wow. So it directly attacks them.
Yeah, it disrupts their transmembrane potential, making it physically impossible for infectious aerobic organisms to survive or colonize there.
So it's not just a local thing.
Not at all. This localized chemical barrier serves as the body's primary line of defense against much broader systemic threats. It significantly reduces the risk of ascending pelvic infections, sexually transmitted infections, and even adverse obstetric outcomes.
So the baseline is a highly acidic, totally hostile environment maintained by this brilliant symbiotic relationship between host estrogen, epithelial glycogen, and lactobacilli fermentation.
Right.
Which brings us to the disruption. Because DIV represents the total structural and chemical failure of this environment. Let's look at the actual histological reality of what happens when this pickling process just stops.
The name itself, the term desquamative, refers to severe premature shedding of the mucosal lining, right?
Yes. Under phase contrast microscopy, a healthy baseline sample normally shows mature, superficial, squamous epithelial cells.
Just standard skin-like cells.
Exactly. But in a DIV state, the microscope reveals massive sheets of parabyssal cells.
Wait, parabyssal, what are those?
They're the immature foundational cells from the deep basal layers of the mucosa. So the superficial layers haven't just gently sloughed off like they're supposed to. They've been aggressively stripped away by a severe inflammatory response.
Oh, wow.
Yeah, which exposes the deeply sensitive underlying tissue. Which brings up the case study from the sources. We have a 42-year-old woman identified as SW. And I mean, when I read her symptoms, it sounded agonizing.
It is. Patients present with copious, purulent exudate, which is essentially a chronic yellow or green discharge.
Because of the white blood cells.
Right, exactly. Massive neutrophil presence. And the exposed mucosal tissue develops petechia.
Those are the little red spots.
Yeah, pinpoint hemorrhages that appear as a fiery red spotted rash. And because those nerve endings are exposed, it leads to chronic, intense burning and severe dyspareunia, which basically renders intercourse physically impossible.
Right, and the case study noted SW was at a constant 7 out of 10 for pelvic pain. She couldn't be intimate with her partner. She had been bouncing from clinic to clinic for weeks. Oh, wait, I want to push back on something. Shedding, like a snake shedding its skin. That sounds terrifying. What is actually happening on a cellular level to cause that?
Well, the sources show the immune system response is just staggering. Along with those deep parabyssal cells being exposed, the wet mount slides are flooded with polymorphonuclear leukocytes, the neutrophils we mentioned.
The inflammatory white blood cells.
Right. The ratio of inflammatory cells to epithelial cells spikes to greater than 1 to 1.
Greater than 1 to 1. That's huge.
It is. The local immune system is essentially saturating the tissue in a state of high alert. SW's trajectory is unfortunately the standard reality for these patients. The visible tissue trauma and the severe pain often lead clinicians down entirely wrong diagnostic pathways. They end up treating for common pathogens while totally ignoring the underlying ecosystem collapse.
Which brings us directly to the core question of the deep dive. We know the lactobacilli are gone, the tissue is stripping away, the immune system is swarming the area. Does the inflammatory tissue destruction, the DIV itself, cause the pH to elevate and the microbiome to shift? Or does a shift in the microbiome and an elevated pH trigger the DIV?
It's the classic chicken or the egg, but the data strongly points to an initial microbial shift acting as the catalyst.
Okay.
The chronological cascade begins with an aerobic dysbiosis. For some trigger that frankly remains unidentified, the robust populations of Lactobacillus crispatus and Ginsengii just collapse.
And without the lactobacilli, the continuous fermentation of glycogen completely halts.
Exactly. The lactic acid production shuts down, which means the chemical barrier simply evaporates.
So the pH inherently spikes.
Yes, rising above that 4.5 threshold, frequently testing at 5.0 or much, much higher.
And with the acidic brine neutralized, the environment is suddenly highly favorable for aerobic pathogens, right?
Yeah.
Organisms that actually thrive in oxygen-rich, higher pH environments.
Exactly. We see a rapid opportunistic overgrowth of enteric and skin flora, specifically things like Escherichia coli, Staphylococcus aureus, Enterococcus faecalis, and Group B Streptococcus.
So to answer the listener's question, it's not exactly that the DIV inflammation caused the drought, which is the high pH. It's more like a disruption caused the drought,
Right.
the loss of the lactobacilli, which allowed weeds to grow.
The aerobic bacteria.
Right.
Yeah.
And those weeds basically triggered a massive immune system fire, which is the localized DIV inflammation.
That is a perfect synthesis. The causality becomes clear. The initial loss of lactobacilli causes the elevated pH. That alkaline shift permits the massive overgrowth of aerobic bacteria, and it's only then that the immune system detects this huge pathogenic load.
Because the body realizes something is very wrong.
Right. The epithelial cells recognize the virulence factors produced by, say, the E. coli and Staph aureus. This triggers toll-like receptors that initiate a massive pro-inflammatory cytokine cascade.
The body's alarm system goes off.
Exactly. The localized immune system mounts an aggressive, targeted attack on the mucosa to fight off the aerobic invasion. And that immune response is what results in the severe inflammation and the desquamative shedding of those parabyssal cells.
It's just wild. The dysbiosis and elevated pH set the stage, but the immune system's hyperreactive attempt to clear the aerobic overgrowth causes the actual pathology of DIV. It's friendly fire, basically.
Yeah, and it proves why this matters so much. It shows DIV is an inflammatory process intertwined with the dysbiosis, not a standard, easily communicable STI.
But it creates this vicious feedback loop, because the inflammation strips away the superficial epithelial cells, meaning there's less glycogen available. which makes it even harder for any surviving lactobacilli to repopulate and restore the acidic environment.
Right. The high pH locks the condition into a chronic state.
But this mechanism leaves us with a glaring gap in the pathology. If the loss of the lactobacilli kicks off this entire destructive cascade, what causes that initial population collapse? Like, why do the bouncers leave the club in the first place?
And that is the million-dollar question. The clinical literature is remarkably transparent about this limitation. The absolute etiology remains completely unknown.
Wow.
Yeah. Because DIV frequently presents in perimenopausal women, though, like the patient SW who's 42 and cycling regularly, it can happen at any age. But the historical assumption was always that declining estrogen levels were the root cause.
Hypoestrogenism. Right, because if estrogen drives the glycogen production, a drop in estrogen would starve the lactobacilli, setting off the chain reaction. Couldn't this just be low estrogen from menopause or maybe like a vitamin deficiency?
Well, what's fascinating here is that those common assumptions have been explicitly disproved. Researchers have rigorously dismantled the estrogen theory.
How so?
They ran clinical trials where they treated perimenopausal DIV patients with high-dose topical estradiol. If the root cause was simply estrogen deficiency, the glycogen should have returned, the lactobacilli should have repopulated, and the inflammation should have subsided. Right?
It would make sense.
But it didn't. The parabasal cells persisted, the purulent discharge continued, the pH remained elevated. The estrogen did absolutely nothing to reverse the clinical markers of DIV.
Wait, really?
Yeah.
Nothing?
Nothing. And the sources also detail similar studies ruling out vitamin D deficiency. They measured serum 25-hydroxyvitamin D levels across DIV cohorts and control groups and found absolutely no statistically significant correlation.
And obviously, the clinical guidelines firmly rule out the idea that DIV is a standard communicable bacterial infection caused by a single outside pathogen.
Correct. The current prevailing theories within vulvovaginal specialty centers focus on a genetic or autoimmune vulnerability.
Meaning the body is pre-programmed to overreact.
Basically, some researchers propose that DIV is an aberrant localized immune hyperreactivity to the patient's own commensal flora. Another prominent theory suggests DIV may represent an early isolated mucosal presentation of erosive lichen planus.
Which is a systemic inflammatory condition, right?
Exactly, one that specifically targets mucous membranes.
So because the initial trigger is a total mystery and the pathology mimics other conditions, patients like SW are trapped in a nightmare cycle of misdiagnosis.
It's incredibly common. DIV is strictly a diagnosis of exclusion. A clinician cannot simply swab for a PCR panel. They have to systematically rule out every other possible cause of vaginitis before arriving at DIV.
Right. I mean, SW tried self-treating with boric acid, probiotics, yogurt. None of it worked.
Well,
And her previous doctor saw the elevated pH and abnormal discharge, and their immediate reflex was to diagnose bacterial vaginosis, or BV. They gave her metronidazole, which obviously failed.
because BV and DIV look entirely different under phase contrast microscopy.
How so? For the listener who might not be looking down a microscope.
Well, BV involves the proliferation of anaerobic bacteria, like Gardnerella, not aerobes. A BV wet mount reveals what we call clue cells, which are epithelial cells whose borders are just completely obscured by adhered bacteria.
Okay, so it looks fuzzy.
Exactly. And importantly, BV lacks that massive neutrophil flood we see in DIV.
Got it. And doesn't BV have a specific smell?
Yes, BV typically presents with a distinct amine odor upon the addition of potassium hydroxide. It's called the whiff test. DIV completely lacks that odor.
So you have to rule out BV. What else?
Clinicians also have to rule out candidiasis, which is a yeast infection. That typically presents with a curd-like discharge in a normal low pH environment. And they have to rule out trichomoniasis, where you'd clearly see flagellated, motile trichomonads moving around on the slide.
Which is why you simply cannot diagnose DIV without immediate in-clinic wet mount microscopy.
Ah.
But here is where I want to push back on the clinical guidelines presented in our sources.
Okay, sir.
We've established that researchers prove DIV is not a standard bacterial infection. We know it's a complex aerobic dysbiosis linked to an immune hyperreaction. Yet the gold standard treatment recommended by the IUSTI and WHO centers on prescribing clindamycin, which is a broad-spectrum antibiotic.
Right.
Prescribing a heavy-duty antibiotic for a condition that isn't a true bacterial infection seems completely contradictory, especially when antibiotics are famous for destroying microbiomes further.
It's a very fair point. The reliance on clindamycin does appear totally paradoxical on the surface. But let's look at the standard treatment regimen. It involves topical intravaginal application of either 2% clindamycin cream or 10% hydrocortisone, typically for 2 to 4 weeks.
Now, the hydrocortisone makes sense. It's a potent steroid that directly downregulates the immune response, stopping the inflammatory tissue destruction.
Exactly. The efficacy of clindamycin, however, relies on a dual mechanism of action.
So it's not just functioning as a standard antibacterial agent.
Only partially. First, while DID isn't caused by a single infectious agent, remember that the environment is overrun by those aerobic opportunists, the E. coli and the staph.
The weeds in our analogy.
Right. Clindamycin aggressively clears out that specific aerobic overgrowth, which removes the pathogenic load that is continuously triggering the epithelial toll-like receptors. So it clears the antigen stimulus.
But the sources suggest its efficacy actually goes beyond just clearing the aerobic bacteria. Don't lincosamide antibiotics like clindamycin have intrinsic immunomodulatory properties?
They do, yes. Independent of its antimicrobial activity, clindamycin actively suppresses the synthesis of pro-inflammatory cytokines. Specifically, it suppresses tumor necrosis factor alpha and interleukins produced by the immune system.
Oh, wow.
Yeah, so it alters the local immunological environment, actively dampening the immune panic while simultaneously clearing the aerobic overgrowth.
That's incredible. It's acting as both a targeted herbicide for the aerobic weeds
Yeah.
and a fire retardant for the inflamed tissue.
Exactly.
However, the clinical data highlights a pretty grim reality regarding this treatment, because clindamycin and hydrocortisone only address the downstream effects, the dysbiosis and the inflammation, and do not address the unknown root cause. The relapse rates are exceptionally high.
Very high. Once the initial 2 to 4 week induction therapy ends, a significant percentage of patients experience a rapid return of symptoms because the underlying vulnerability, whether genetic or autoimmune, remains.
What do they do?
The clinical guidelines heavily emphasize the necessity of maintenance therapy. Patients often require the intravaginal application of the steroid or the antibiotic once or twice a week for anywhere from 2 to 6 months.
That's a long time.
It is. It's a prolonged strategy to keep the immune system suppressed long enough for the vaginal tissues to heal. The hope is to allow the lactobacilli to naturally reestablish that acidic baseline on their own.
It requires meticulous clinical follow-up. You are literally trying to manually manage an ecosystem until it can stabilize its own feedback loops again.
Precisely.
So what does this all mean? Looking at the entirety of this diagnostic puzzle, a very clear imperative emerges for the listener. The human microbiome is an intricate, highly volatile chemical environment. DIV demonstrates perfectly how the loss of a specific protective bacterial strain and a subsequent shift in pH can trigger a devastating tissue-destroying localized immune response.
Yeah, the balance is incredibly delicate.
It underscores a vital reality. If you are navigating chronic, complex symptoms, you must advocate for comprehensive diagnostic testing. Demand the pH testing. Insist on the in-clinic microscopy. Recognizing a condition like DIV requires looking past standard, generic treatments and demanding a clinical evaluation that actually respects the complexity of your body's ecosystem.
Absolutely. And, the clinical curiosity required to properly diagnose DIV opens the door to a much broader, almost provocative immunological question.
Ooh, tell me.
Well, we've established that DIV involves a localized dysbiosis triggering a severe immune reaction. Now, in gastroenterology, we already recognize the gut-brain axis, right?
Right, the reality that the gut microbiome communicates directly with the systemic immune system and the brain.
Exactly. So it raises a fascinating implication for the future of mucosal research. If the vaginal microbiome is capable of this level of intense, localized immune signaling, like we see in DIV, it is highly probable that it is communicating with the broader systemic immune system in ways we just haven't even begun to map yet.
Oh, wow. So a localized collapse like DIV might not just be an isolated event.
Right. What if it's serving as an early biological marker, like a warning siren for a larger, body-wide autoimmune or inflammatory vulnerability that we simply lack the diagnostic tools to measure today?
A localized dysbiosis acting as a window into systemic immune function. That fundamentally changes how we view these diagnoses. It's not just a local issue, it's a systemic dialogue.
Exactly.
The deeper we look into these localized ecosystems, the more we realize how interconnected the entire biological network really is. Keep digging into the research, keep questioning the standard narratives, and never settle for a diagnosis that ignores the complexity of the whole picture.
Yeah.
Thank you so much for joining us on this deep dive. Until next time.